Good morning, my Foresight TV friends. You'll notice my background is completely different today. I wrote about taking snow days, and I'm taking my snow day today and Monday and through the weekend over at the Mendocino coast. But I had this Foresight TV episode scheduled, and I'm very, very excited about my guest who's running actually just a little bit late. So I'm sitting here at the Mendocino coast. I'm going to start with our little intro clip. And he's in an airport. I'm sitting in an Airbnb home on the Mendocino coast talking to you. So you're going to see different backgrounds, kind of interesting backgrounds today. But I'm going to start with our intro video. And hopefully by the time it's done, our guest will be here. Welcome to Foresight TV, where we provide leadership food for the soul, helping senior living organizations have higher occupancy, lower turnover, and better cultures. Today's episode is made possible through the generous support of Connected Living, a technology company that helps senior living communities effectively communicate with residents, families, and team members. Here's today's show. Hello, Raphael. Your timing is perfect. I don't think I've ever done a show with somebody in a mask, but I know you're in an airport. And so I am delighted that you could make it. I know these are, we live in interesting times, so everything has to be very different. You'll actually see that sort of a kitchen background where I am at. I'm out on the Mendocino coast in Northern California taking a few days off, but I am really, really excited. So why don't we actually start by, maybe we can start by talking a little bit about what medically home is the term you use, correct?
Correct.
And you are co-founder of the organization. You're a VC-funded startup?
No, strategically funded company, not VC funded.
Yeah. And what is it, just out of curiosity, what's the difference?
VC funders are basically investors for a financial return. Strategic funders are enterprises and entities that are in this to partner with us to actually deliver the model, as opposed to just create a financial return. Big difference.
Yeah, clearly that's the case. So let's talk a little bit. Now, you don't actually use the term hospital at home. As I understand that that's a trademark term, so it's medically home, or is that a generic term?
In terms of the category, it's either hospital home, hospital at home, home hospital. We use the term virtual hospital, but our company's name is medically home.
Okay, perfect. So my audience are going to be people who primarily who operate or serve in the senior living industry. And so that could be assisted living, independent living. We do have some skilled nursing folks who are also part of our audience. So just sort of give you the context of what we're working in. So let's actually talk about what hospital at home is, how long it's been around, and what it means.
Sure. So it began about 25 years ago with some research driven by some academic research. The principal person in the field is Dr. Bruce Leff at Johns Hopkins Medicine. And the basic theory was patients who experience acute illness in a hospital, they started to ask the question, what would it be like if they recovered from that illness at home instead of the hospital? How would it affect their infection rate, falls, cognition, obviously mortality? Satisfaction. So there were a series of measures, and researchers were curious, if I recovered at home, forget about how difficult or easy it is or how I get paid for it, what's the benefits of using the home as a site of care? And the research was very robust, done around the world, multiple clinical trials, a lot of it randomized clinical trials, so pretty strict science. And the overwhelming evidence was patients prefer it, the economics are superior, the clinical measures are better. Patients can sleep in their own bed. They fall less, obviously don't have a hospital-acquired infection. They're more engaged with their own care. So it was an academic exercise, and everyone overwhelmingly said, if we could, what a great idea if it could be hospitalized at home instead of the hospital. So that was called out 25 years ago. About 13 years ago, I was joining a board of a hospital, and my dad was admitted there as a patient and unfortunately lost his life for medical errors. And that's how my journey began. And what I was interested in is the cost of operating that hospital, the overhead cost. So think of the hospital as clinical care at a hotel. What was the hotel cost? to keep the patient there, and the cost associated with the hotel. What if we use that cost, kept the patient at home, and provided much more care over a much longer period of time? So as an example, in an average hospital today, the length of stay is about 4.5 days. Almost nobody recovers from acute illness in 4.5 days, which is why they end up after the hospital in skilled nursing facilities, as an example, or rehab. And they typically need another, call it 12 to 15 days. And frequently, about 20% of the time, about those patients after the skilled nursing, they need to be rehospitalized, which suggests that there really isn't enough time to care for the patient to have a reliable, better outcome. So our idea was, what if we took the really sick patients, the high acuity patients, home for 30 days and substitute not just for the hospital, but for all the care that follows, and stay with the patient until the patient is fully recovered. To do that, you have to have a different cost structure, which means you're actually using the patient's home as a hospital. So that was the idea. The industry, which is now new, of providing hospital care at home is divided into two parts. One part is doing very low acuity care at home. So think of cellulitis, a low heart failure. Those are a pneumonia, but think of somebody that's chronic, elderly, weak, frail, and they now have pneumonia, COVID, and heart failure. They're very sick. To hospitalize that patient at home requires a whole series of skills, capabilities, infrastructure, technology to reliably get all the services that are currently available in the hospital delivered to you at home, which means you have to take Amazon, the hospital, and Uber, package it together and bring it to your front door, which is what we've built over the last 13 years. So the hospital at home industry is fairly new as a business, and it began in earnest, in my opinion, with substance since COVID, because of the challenges that hospitals have had to care for the number of patients that are coming in.
So when you're taking care of really acutely sick individuals at home, the two challenges, I guess, that I see is that you need medical professionals there, and you need stuff. And that stuff could be, a diagnostic, and probably a lot of it is just consumables and things like that. And so, are they getting 24-hour nursing care at home, or what is that? What is? Let's start with the labor part first.
Let's start with the model first, so you get your arms.
Okay, you know better than I do. So
it's a new concept, so it's a little complex the first time you hear it, but it will make a ton of sense to you. So if you and I wanted to take care of your parents at home and they were sick, what would we do if we couldn't use the hospital? Let's say the hospital's full. What would we actually do, and how would we do it? So let me walk you through. There are 4 things that you need to do this. The first is, a very ill person needs 24/7 medical care supervised by a physician, typically a hospitalist, an emergency room doctor, or an intensivist. You can't put them in a car and have them go back and forth to the patient's home and efficiently and safely care for them. So you have to centralize them. So you put those physicians in a medical command center. To think of NASA, of watching the astronauts in space, now imagine physicians managing patients that are in their home 24/7. Not just managing them outbound, but being available 24/7, not just to the patient, but importantly, to the family. So if you've ever had a relative, or if you've ever been hospitalized and you want to reach a doctor 24/7, that's not the easiest thing in the world to do. So the first part of the idea is a command center staffed with physicians who care for patients at a hospital level, supported by nurses, supported by nurse practitioners, and supported by service coordinators who actually operate and make sure orders that are delivered by physicians are executed. So that's the command center. And that's 24/7, providing care anywhere that patients are. And you could do that because of telemedicine, obviously. That's the first part. The second part, the patient's home has to be turned into a temporary hospital unit, which means, like you said, stuff. We need medical equipment. We need supplies. We need medication. We need monitoring devices. We need backup power. We need backup cell signal. We need emergency response systems. We, in essence, in 40 minutes or less, have to set up that home to be safe site of care for high acuity. That's the second thing. The third and the hardest part is all the services we deliver in the hospital today. So think of labs, x-rays, sonograms, EKGs, procedures like a catheter, medication, phlebotomy, all of those services have to be brought to the patient's bedside around the clock as needed. So we have to, in essence, take the services that have been historically centralized in a building and Uberize them, Amazon them to bring them to the patient's bedside. That's the third thing. And the fourth and the final is the software necessary to run a virtual hospital is different than the software necessary to run a bricks and mortar hospital. So when you add it up, the four pieces, you basically have 24/7 physician-led medical care, centralized, distributed technology into the home, distributed services into the home, all the services necessary for high acuity care, and the software that operates that. Together, that's medically home. So if you have an elderly, if you have a relative that has, COVID or pneumonia or, heart failure combined with other diagnoses, what you do is you basically admit them to their home for an acute stay. They're typically with us anywhere from 7 to 30 days until they fully recover, and all the services that they need are ordered by physicians, managed through this command center, and then brought to bedside. We're monitoring them 24/7, and that allows us to have the best of all worlds. The patients at home where they want to be, the access to information of the status of the patient is real time, and the ability to dispatch services to the patient's side is also 24/7. And that's the model.
And are you in California? What states are you in?
California, Oregon, Ohio, Massachusetts, Wisconsin, Florida, and we're adding Texas, Oklahoma, and North Carolina as we speak.
Right. And then who pays for it? I guess that's sort of the big question.
The payers are traditional commercial payers like the Anthems of the world, Medicare Advantage payers, and Medicare now pays for it as part of a hospital at home waiver called Hospital Without Walls, and they began paying for it a few months ago.
So it would seem like this would be an ideal fit. And I don't know whether you've talked to any providers about it or even thought about it, but it would seem like it would be like an ideal solution for assisted living and non-licensed independent living, senior living communities, really in potentially two respects. One would be, of course, for existing residents who are already there. But I would also think it could be for people who are maybe who would like to be in a home-like setting, but have no support staff. So I guess maybe that comes back to this question. So do you supply somebody who's with the patient in a medically home? Is somebody with them 24/7, or does the family supplement that, or how does that work?
It really depends. So let's say in the first 2 days of care, let's say a person has recovered from surgery, as an example, and there's a risk of fall, we would provide somebody around the clock for, anywhere from 1 to 3 days. But most patients can actually move around okay, and they have family members, so it's not necessary to actually have somebody providing that kind of support. In an assisted living context, you have that kind of ADL support in place. What really makes this compelling, at least in my view, for assisted living, is we also provide emergency department at home. So imagine you have an iPad in your facility, in your kitchen, and you're not feeling well, you're short of breath, or you're dizzy. You push a button, and there's the medical command center, and we could dispatch a clinical team to your home rapidly, care for you, and if you need to be admitted in the hospital, you move from your living room to your bedroom. If you just need to be cared for in place, we care for you in place. The point is, from an assisted living standpoint, you have your own hospital at your fingertips in your own home. That's the compelling idea for assisted living.
Yeah, to me, I just, you start talking about this and I just get really excited about it because I think it's a better way to more broadly serve existing residents. But I guess the other thing I find kind of an interesting idea is that I suspect there very well could be times when you've got people, again, who maybe don't have close family support, or the family can't do that. And you might be able to even set up in a senior living community for that week or 30 days where it would help help the community and help that individual and give you another vehicle at maybe a lower cost and probably a better, higher quality of life. So
agreed. The idea of having your own emergency department available as opposed to today where you call 911 and they transport you to the hospital. Imagine if the hospital comes to you and provides that emergency care in your own home. And if you require a high level of care, it's actually brought to you to your home. It changes the dynamic of the definition of your home and healthcare, and particularly for assisted living, because there is support. There is ADL support in those settings. So it's a perfect fit, and that's an area I've been greatly interested over the last few years.
Great. So I suspect that either live here or over the next week, this will get watched by some executives who say, I got to do that. So, or at least I've got to be talking. So do I connect them with you, or what should I do to get that?
That would be fine. Years ago, I don't remember how long ago, it was probably, I'm guessing 4 years ago, 3-4 years ago, I was at the Consumer Electronics Show, and a gentleman that was with the Economic Development Office in Phoenix actually shared this idea with me. Said we have more and more people moving in that are looking for health care for the rest of their lives, and a lot of them are assisted living or gated communities. Could we provide this capability? And because of the scale, obviously there's some efficiencies having everybody. So I was very, very intrigued with that idea. So there's a good fit between what we're doing and that kind of setting.
Yeah, no, I think it's a huge, huge opportunity. I had a couple of. So, have you done it in any kind of in any senior living? Have you worked in any senior living communities at all at this point?
Not as a model, but we did have a patient, a very, very high acuity patient that we moved into a senior living facility because he needed to be in that setting, and we cared for him there. And to your point, it's actually a very efficient setting because it has support services already in place. And it was actually, we had a very good experience, and so did the patient. So we've actually done it, but it hasn't been a focus of our model up to now.
So you talked a little bit about if you had an acute incident when you were in a hospital home, you dispatch a team. Can you talk to me a little bit more about what that looks like and how long it takes to mobilize that and that kind of thing?
So imagine that in the command center, the medical command center, you have physicians, nurses, nurse practitioners, and coordinators. And now I'm sending, let's just say it has to be rapidly dispatched. I send a paramedic or an EMT to your house. That paramedic or EMT is connected to the clinician in the command center. If you've seen all those military movies where we have medics in the field taking care of soldiers connected to a physician in a central command, that's the model. It's called tethering, where you're tethering the clinician that's centralized to the clinician that's at bedside. So what we would dispatch if we had to dispatch rapidly is a paramedic connected to either an emergency room physician or a hospitalist. They're at bedside, they're doing labs, they're doing x-rays, they're doing tests, they're doing a physical, obviously history, and they're coming up with the diagnoses. Once it's clear that they either require hospitalization or they can be resolved without hospitalization, then the next thing that follows, and let's say they require hospitalization, the next person that would arrive would be a nurse practitioner. We would reconcile their medications. We would start to put them on a program of care. They would look very much like a hospital. In other words, they have IV infusion, they have checkups, regular labs, monitoring, except they're doing all of that in their home. So all the services they would get at bedside, those touches, are brought to them. And typically, let's call it 5 to 7 days. With COVID, it's typically around 7 days. Their acute status has resolved. And now we're in what we call the restorative phase, where we're actually working with the patient and the family. Well, how did this happen to begin with? Is the patient not being adherent to their medication? Or they have issues that are dietary? Do they have transportation issues to get their medication? So whatever those social determinants are that typically contribute to an acute episode, we get at that very, very aggressively to prevent the possibility of them representing.
So what kinds of things can you and can you not do at home? Ventilators, can you do ventilators at home as a for instance?
Yeah, today the things we're not doing, why I'm in Florida, because pretty soon we will be able. Today we do not do ventilators. Today we don't do transfusions, and today we don't do pediatrics. Within a year we'll be doing all three, and we have a vehicle to do all three. And then within a year we'll be doing chemotherapy at home. So the real challenging things that we've been working on, within a year we'll be in all four of those.
Wow. So are we going to get to a point where hospitals are going to shrink because most of it's going to move? I assume the cost is lower to the system than when it's in an acute hospital?
It's typically 20 to 30% less cost. but there will always be a very significant role, obviously, for the hospitals for serious and complex care. So if you're trying to imagine what would the impact be, about 30% of the 35 million hospitalizations in a physical hospital would move to the home. The balance, the 70%, would stay in the hospital. That's not going away. But 30% of 35 million admissions and 30% of $1.3 trillion is a significant movement of volume.
It is, and I have a good friend who's an operator, Juniper Community. Her name is Lynn Katzman, and I hope she's watching because this is her kind of thing, and I'm going to actually make sure she's connected with you. But they've been doing some things, some preventative and some wellness and some health kinds of things in their communities already, where they've been able to increase. I don't know what the current numbers are, but they were able to increase their lengths of stay for a month or two on average, which, a month doesn't sound like a lot, but when you're talking about across 1,000 individuals, that's significant economically, and it's significant for quality of life for lots of people. So this is really, really interesting, cool stuff. This is something I think that everybody ought to be looking at. And is when you talk about the six upcoming states, is that for you or is that for everybody? Or, is it being done in all 50 states right now by somebody?
107 hospitals have applied for a hospital without walls waiver, which means the Medicare waiver to do hospital at home. That's on a public website. I can get that for you if you like. I think it covers the top 40. I'm guessing it covers the top 40, 45 of the 50 states today. That's obviously independent of what the states we're in. It's a lower acuity model that everyone else is using, but it is going to be available. This lower acuity model will be available probably, I'm guessing, about 40 states based on the number of hospitals that have responded.
Gotcha. And so where you're doing this, do you have to be connected with a local bricks and mortar hospital to do this? It sounds like.
Yeah, our business strategy is to partner with hospitals. Like one of our biggest partners is the Mayo Clinic, as an example. So our view is we want to enable hospitals to provide this care as opposed to compete with them and provide care around them, which is not part of our philosophy. So most advanced hospitals now recognize this model works. It's in patients' best interest. It provides a lot of value to the healthcare system economically. And it's really in line with creating more capacity, because the one thing we learned from the pandemic is we didn't have enough beds.
Yeah.
When we didn't, we had some real challenges.
Yeah. And again, just the idea of what it can do to protect you, in times, particularly in time with COVID and the infection rates. One of the things that's been curious to me, really very little conversation about the number of infections that have actually come out of hospitals, and yet my sense is those numbers are actually fairly significant. And I'm thinking I'd rather be at home if I had COVID than I would in a hospital, well, much less, or maybe if I didn't have COVID and I was afraid of getting it. So it makes a lot of sense. So,
by the way, the volume in emergency departments across the country is dropping precisely for that reason. There's a lot of fear that particularly older patients have of going to the hospital, and they're seeing a significant decline in the actual activity in emergency departments, which is very concerning to a hospital. Very concerning.
Yep, absolutely. Well, listen, this has been a great conversation. I know you've got you've got a flight you're just catching, right?
And not till 3:30 of an hour.
Yeah, lots of time. Is there anything else I should be asking you about?
I think the way in which, at least I view the world, I lost, I think I told you, I lost one parent to medical errors. The other parent I lost to a pretty significant healthcare issue. Both my parents were Holocaust survivors. They made it through 3 concentration camps and didn't make it through the healthcare system, which is, I guess, ironic. I guess the most important thing I'd like to share with you, because I was a caregiver, the way in which we've organized care for our seniors is based on waiting for something bad to happen. And when it happens, we basically call 911. And it's typically a family member, not the patient. My husband's not breathing. A child says, Dad's disoriented, so we call 911. An ambulance comes, transports us to the emergency department. It's very frightening. There's obviously COVID risks and other risks. And then the hospital, in many cases, is busy, so they have to wait in the emergency department, and it takes a while to decide whether they admit them or not, and then they're admitted, and they go through this cycle. The actual experience in the hospital, lying in a bed for an extended period of time, not moving around like they would if they had to walk their dog, as an example. And then they end up in a skilled nursing facility. Same thing, they're lying around for 15 days. Now they need rehab to basically go back to where they were. So that cycle of caring for elderly needs to be rethought. And in our view, if the patient requires care, there are three things that you need to start with. If the highest acuity care is the hospital, and you're providing the hospital to the patient around the clock, an emergency department that can come to them, or if they have an issue and they need to talk to someone at a high acuity level, what you're really providing is 24/7, 365 access. And the best way I describe it is, imagine that your son or your brother runs a large hospital, and now your sister is sick. You would call your brother first because he runs a hospital, right? And he would say, don't worry, this is what's actually going on. I'm going to send somebody to the house. We'll take care of it. That's what everybody wants. That's what we've built. We've built something that everyone has access to the highest level of care 24/7. And if they need lower level of care, we can facilitate that. But the platform of assisted living is not just assisting them with daily activities, assisting them to get access to care that isn't driven by having to drive to a facility.
Yeah, I guess what really, until we talked, I hadn't really thought about it in this context, but being in an assisted living community as an operator and having a contract with, that I don't know, where I've sort of already got this arrangement, and that, how many of those times where we call an assisted living community calls 911 because they don't know what to do. And of course, one of the things we've talked about for years is that you call a physician, something happens in the evening and you call the physician, and it's a lot easier for the physician to say, just send them to the hospital, when they don't really need to be in the hospital. And so the idea that you've got this this command center of physicians available to be able to short circuit that, because we do know that there are lots of times where you don't actually need to if a physician could get on a call or do the equivalent of a telemedicine, that the patient would, or the resident would, need to be transported. And so having this all prepackaged is huge.
And the most important part is telemedicine allows for a clinician and a patient to have a consult, but telemedicine doesn't allow you to dispatch services at bedside to care for the patient. Our view is you have to have both. You have to have the command center, the telemedicine, and we call it an effector arm. It allows the actual consult to affect in the delivery of care at the patient's bedside, that we're bringing the care to them. So you need both, the telemedical connection and the effector arm.
So how does, I guess that maybe the sort of next question that becomes important on that is, how does the sort of, if it's where somebody doesn't need what I would think of as sort of traditional is not quite the right word, but if somebody doesn't need longer term, meaning a day to 30 days of care, but just sort of an episodic thing, is reimbursement a problem for that?
It really depends on who the payer is. The answer is it's evolving very rapidly because of the market and what's happened with COVID. I would say within a year or two maximum, most of these interventions at home will be paid for because they provide a very significant improvement in care. I just came from a meeting of something that I'm intensely interested in, which is NICU care at home. So babies, an average NICU stay is about $7,000 to $10,000 a day. And these babies who stay there, anywhere from 2 weeks to 3 months, sometimes it's upwards to 6 months. A lot of them require feeding, a little bit of oxygen support, and phototherapy, all of which can be done at home. So to imagine a NICU at home, supported by a command center of neonatologists, that thought process is the same thought process that we talked about in our call today. You're just basically mobilizing the services that traditionally we thought had to be centralized, but now we can.
What I was going to say is you almost have what I'm sort of going through my head right now is what you're almost just seem to be describing is the emergency department at home as well as hospital at home, and I just really like that idea.
That's exactly right. That's exactly what we're doing.
Well, listen, we're about out of time. Thank you very much. I'm so sorry for the technology difficulties.
No, it's fine.
You in an airport and me in a vacation home. It just, these things happen. So again, I appreciate it. We will put some links in the posting on YouTube and LinkedIn and Facebook about how they can get more information from you guys, talk to you guys. But I'm 90% sure you're going to hear from some really significant operators. This is really cool, cutting edge stuff. So I appreciate it. I've got to do one other sort of piece of commercial business. As a lot of you, didn't stay up. As a lot of you who are part of our audience know, we're just in the process of starting a texting community. We will do some bonus cool stuff for you. So if you text to 916-659-5287, just the word or the letters TV, you will get a quick response back to tell us who you are, and you'll get some extra bonus stuff that you will only get for being a part of that community. Raphael, thank you so much. This has been really, really cool. I'm thinking I'm going to need to do this again with you in about a year or so, and we can start hearing how it's working in senior living.
That would be great, and thank you so much for your interest. Really appreciate it.
You bet. Thank you.